Welcome everyone. Here we are. I'll just wait till you quiet down a little bit. So welcome to the Global Classroom. It's kind of exciting. Today we don't have actual global classrooms because a lot of the people in Russia currently and in England have flus and they're really sick, and it's also later in the evening for them. But the good news about the Global Classroom is that we're actually live streamed. We're filming it through the Cafe and Sunny. So later on we can access this lecture online through Durham College's YouTube channel. So I'll send you all the links for that and everything. So you don't have to take notes, you just have to enjoy and listen to Dr. Clark. I asked Dr. Clark how I should introduce him because I could probably go on for half an hour with all the credentials, all the papers he's written, all the experience he's had. But I think I'll just introduce Dr. Clark, who we've all gotten to know over the years, who's been with us here at Durham College, has a very impressive resume as far as dental is concerned and the information that he has. Today his lecture will be on eating disorders, so enjoy everyone, and thank you for coming, Dr. Clark.
Thank you, Astrid. Good afternoon, everybody. I had the pleasure of meeting most of you last Friday for my first session in your semester, so it's great to see you again. I think you're going to be stuck with me after I finish here for another hour and a half this afternoon. Usually the lectures are the other way around to kind of introduce this topic, but so we'll just have to figure it out going this way. It's great to be able to present this topic. My background in practice has been, I've been at Ontario Shore Centre for Mental Health Sciences in Whitby, which you may remember or know of as Whitby Psychiatric, Whitby Mental Health Center. It's gone through a lot of name changes. I've been in charge of the dental clinic there for over 28 years now. It's downsized, unfortunately, to 2 days a week, and I'm not sure what the future holds, either for myself there or for dental services in general. However, the experience that I've gained in these topics, I've tried to present to groups such as yourself. This may be the only lecture that you're going to get on eating disorders, other than what you might read in a book or a journal. And so there's really two reasons why I present these topics. This one, and of course later this afternoon, is first of all to empower you a little bit more on knowledge of severe mental illness, the different categories, eating disorders being one. But the second reason is really to talk to you about it in a sense that, as you'll see from the statistics later today particularly, these diseases affect everyone, not just our patients. That's what I'm talking about our patients, because we will encounter these patients in our practices. But I'm also talking about the community, your friends, your families. I know that I will touch a nerve at some point in one of these lectures with one of you. But by getting up and talking about it, as you've heard in the media recently and so forth, I think it's important that you feel more comfortable. You may actually be the one person in your practice later on that might open the door for somebody who's dealing with some of these very serious illnesses. And then we'll throw in dental because we're here. That's our profession. So otherwise, I probably couldn't get up here and talk about it. So with that in mind, I'm going to start with eating disorders. One of the serious of the mental illnesses that are out there, and we're going to, again, I keep referring back, we're going to talk about more this afternoon, the categories and so forth, but we're going to jump right into it with this particular lecture. Eating disorders, in general, if you look at psychiatric illness, or any other medical illness in your patients, the oral health really reflects what's going on in the body, good and bad, good times and bad times, ups and downs. And so you've got a patient who's dealing with serious depression. You have a patient who has psychoses, psychotic thinking, a patient with eating disorders. Those conditions are going to impact how they want to look after themselves and how they care. And basically, in the depths of depression, people just don't give a damn. They don't care. And you're going to see it. And then you're going to see somebody who goes into recovery, who's responding well to therapy, medications, psychotherapy, and so forth. And all of a sudden, things are going to change. Their attitude is going to change. They're going to start wanting more from you. So that's just kind of what that refers to. I just lost my. Are you okay?
Yeah.
Oh, it's not on the screen. No, the PowerPoint. I can see my. I'd rather change it and drop that screen and put the PowerPoint on. But. So since October 2014, Ontario Shores opened up a specific eating disorders unit. 12 beds, first of its kind in the province. Before that time, families would have to take their, and usually I call them children, but I'm talking about kids that are 13, 14, 15 and above, had to take them out of the province sometimes to the States at great expense, and leave their loved one there. You know, it's just unaffordable to live there for 30 days, 60 days, or however long, 90 days. And so now this enabled families to have access to resources close to home. So instead of somebody from Ottawa going down to the States, they come down here. And we see patients from all over the province. But we need 1,200 beds. 12 beds is not enough. We need 1,200. So this unit has been obviously full right from the start. And there's been success stories coming out of it. There's actually been families coming back and saying what great work the program did for their child, in other words, in dealing with and overcoming, not cure, overcoming their particular eating disorder. And the reason I sort of have a close tie-in with it is because when we got downsized 2 years ago by the hospital in terms of looking for more money, my assistant who worked with me was downsized as well to 2 days a week, but that wasn't sufficient for her to, you know, and her family, she needed full-time work, and she actually applied and got a position in the eating disorders unit as a sort of office receptionist and so forth. So she keeps us up to date on what's going on there, and so that's sort of a close connection we have. Anyway, eating disorders are really comprise a group of diseases that have both a psychological and a pathological component to it. And it really focuses around one's issues with food and how one deals with it and uses it as a coping strategy. And so it really focuses on issues around food. And what I might do, this is probably be a good time to do this, is I could give you a really fancy diagram or graph about all the possible causes. You could say, well, it's due to advertising on television, you know, promoting thinness, this is equals success, whereas this does not equal success. All those kinds of concepts, which is partly true. But not everybody's affected the same way. It's how that individual in particular uses that information and how they embrace it or don't embrace it and carry forward with it. But what I think is more relevant is an example of an intake assessment for a young patient who's been admitted to our unit, eating disorders unit. I'm going to read it to you. This is what the physician does in the first interview with these patients. And I think any one of these, and I've got a whole bunch of them, I could read to you and describe exactly what these kids are going through and what they've been through to this point in time. And some of them, you know, as young as 13 or 14, have been through more in their life, in their short life, than I could ever imagine. Hopefully you could ever imagine too. So let me read this to you and then we'll carry on. Hopefully the slides will be out by then. You want to see my stick?
Some issue from your doctor. I was
Oh.
working with mine.
Okay.
So I'm trying to pull that.
So why don't you just take the stick down?
Yeah, and you can just use my laptop.
Sure. I'll use your clicker to No, go ahead and do that. That's for the change. around, eh?
So while we're just waiting here for a sec, I passed around the journal article. Some of you got one on Tuesday already, so I'm just passing it around again for those that didn't get it. And this is just Dr. Clark's journal article published in the Canadian Journal of Dental Hygiene in 2010. So it's also posted online on your website. So most of you should have one already. Do that on Tuesday. If not, it's oh, good.
That doesn't want to advance. Probably hasn't recognized the device.
So you want me to change the slides for you?
Yeah, whoever needs one, if anyone here needs one, we've got it.
I could, oh, I can't.
Pass that over
If
there.
you want, I can put my laptop there.
Sure. Would that be okay?
No, I haven't.
I just say click slide.
Because I don't know if this board is not.
This is not recognizing this. Yeah. Okay. Okay, let's just pick up where we left off. So as I said, eating disorders in general, group of psychopathological disorders, two words put together, affecting relationship with food and how it's manifested as a disordered eating behavior, outlet to express inner conflicts and disturbances. So this is the really complicated thing, which I don't think it really makes much sense to you, but I think this will. So let me read it through. Just listen, and you'll get a kind of an idea what's going on. Miss X is a 17-year-old girl who lives with her mother. She has an 18-year-old sister away at college and a 32-year-old half-sister living with her father. Parents together for 21 years, then separated in 2009. She worries about her mother. She has been admitted to hospital 15 times in the last 2 years, with stays ranging from 3 days to 2 months. Miss X first developed symptoms when she was in grade 5, age 10. She was struggling with unhappiness and was stressed by her family situation. Her parents' marriage had ended and her father left. Her mother was drinking and she felt that she had to take care of her mother. She decided not to eat breakfast one day and forgot her lunch. She felt different and liked it. She soon discovered that focusing on schoolwork and on her eating and her weight was a distraction from her real emotional issues, and they became habit. The line has been crossed. She was also running on the cross-country team because she thought it would help how her body looked. She had always been small and little and liked the attention for being tiny. She also spent a summer visiting an aunt who was very focused on healthy eating and losing weight. This solidified her behaviors. She managed to evade discovery until about 2 years ago to this admission, when her parents noticed dramatic weight loss and restriction. Since that time, she's had 15 admissions to hospitals all around Ontario, as far away as Ottawa. She has has also had some day treatments and some limited family therapy with her mother. She began purging last year, and at its worst, she vomited every intake. Every time she ate, she purged. She had just been discharged from a 6-week admission, so at the time of this interview, so has only purged a couple of times in recent weeks. She gained 12 pounds while in hospital. She has also used laxatives, and this also started in the last year. She has used them for up to 4 days in a row, but has not used any recently. She struggles with impulsive exercising, where she feels compelled at times to exercise and then will have to get up and move. She is 4 feet 11, her weight is 88 pounds. Highest weight was 120, lowest was 70 pounds. She has made suicide attempts from the age of 10 and was unwilling to go into details at this time. The first time she tried to suffocate herself. She has tried strangulation with something around her neck, cutting, drowning. They all failed. Initially, they failed because she was young and didn't know what she was doing. More recently, she has tried 2 serious overdoses, the last time being a whole bottle of Tylenol, and went to bed. She reports being diagnosed with depression and anxiety, a very common comorbid behavior. She reports being quite sad and at times hopeless. She is very tired of having an eating disorder and wants to recover. She also worries about her mother. She has self-harmed in the past, cutting her wrists and thighs. She has cut only twice when in hospital this last time. She has had 2 episodes where she cut daily for about 1 to 2 months. She finds it helps her feel better because it feels like she's doing something. And this is a common reason for cutting. It just makes that person feel like they feel better inside. Clearly, it's not the way to do it, but so you have and there's a whole host of backgrounds that I could give you. Some worse than that for a young person. Okay, so I'm not going to ask you, do you know anybody, things like that, but I know that some of you or one of you would know somebody in this situation or facing these oh, we got it. Oh, is that you? Okay. So anyway, that kind of gives you a bit of perspective on what these kids are coming into hospital with. Now, having said that, the relative prevalence of these diseases, this group of diseases, eating disorders, is about 1 in 10, and will suffer this in their lifetime. Usually female, but also increasingly males. And in our country, kids as young as in grade 10 are focusing on dieting or thinking about dieting. It's the last thing they should be thinking about at that age, or in school. Having said that, I gave this talk to at Winter Clinic last fall, Toronto Academy of Dentistry, and there was a woman, a dentist in the audience, who came up to me before I spoke, and she just said, by the way, if I leave during the talk, don't take it personally. And I said, oh, of course not, I won't. I'm not surprised why, it can maybe seem pretty boring. And she said, no. She said, I've been dealing with an eating disorder for most of my life. So this dentist, she was in her late 40s, practiced in Toronto. And she said that, she can only sort of hear so much before it really comes back on her, and then she sort of has to get away from it. But she's in treatment and so forth, so she's been actively dealing with this condition. And sure enough, halfway through, I saw her at the back of the room, and she got up and left, and that's fine. And then she emailed me, and she said it was great, thanked me for bringing this forward and so forth, and said if I ever want to call and get some real insight into how this disease affects someone, and we're talking dentists, we're not talking just somebody out there we don't know, to give her a call, and so I did. It was very enlightening hearing it right from the source, what an individual's dealing with. There's really 3 major kinds of eating disorders. There's anorexia, there's bulimia, and there's eating disorder, NOS, not otherwise specified. It's just, I think, something the psychiatrists like to throw in when they don't know really what to call it, so they just say NOS. But mainly anorexia, or restricting behavior, average age of onset around 14 years. Bulimia around 17, 18 years. But again, there's no hard and fast with figures. And as each new generation is coming along, the statistics are showing that it's becoming more common. But it's a very secretive type of illness, as are most severe mental illnesses. And I think you could all give me one reason why, and of course it's the stigma around these diseases. And that's why I'm up here talking about them. I'm not going to talk to you about blood pressure or diabetes, because you hear that all the time, and you know all about that. But nobody wants to talk about mental illness. And I know, even on last Friday morning, I've seen a couple of patients that you've had who are struggling with addiction and anxiety for a variety of reasons. And in the last semester, and the semester before that, and even amongst your own class, I've spoken to one or two students over the past few years who are dealing with depression and so forth. So it is around us. Second most chronic illness in adolescent girls. The highest mortality rate in this age group, and much higher than those individuals who are not affected by this disease. So it's significant, and the mortality is suicide. Unfortunately, we'll talk about that later this afternoon. But that is the ultimate escape for most people, is to take their own life. And as I say, when I talk to hygienists and dentists and whoever will listen to me, in particular hygienists, you're in a position to develop a relationship with your patients. I like to think sometimes more so than dentists, because you see them more frequently. And you tend to have more conversations, just develop a rapport. That's my experience from what I've seen in offices that I've been in and worked in, and even at the hospital. So you have that ability, that unique ability for somebody to maybe eventually have a conversation with you, or let something out that you could take and provide perhaps some information, provide a referral, a contact number, organization, whatever. But just showing that you're interested will just open doors for some people. That's all they need. And I believe that you're in that position. And it's, and I can say this because I'm at the end of my career. I don't care what I say, anything, how it offends dentists, but it's more than just veneers. It's more than aesthetics and the perfect smile and all that. It's the patient. You have a patient. I know you call them clients, but I call them patients. And this is the first thing in your chair is the patient. The teeth are, they're there. They're usually going to be attached to a patient, but you got to get past the patient to the teeth. Majority of individuals with eating disorders don't access treatment, and those largely for the reasons we just talked about, mainly the stigma. Person does not want to admit that they have this illness. They don't want other people to know. They're embarrassed. Because they think you're going to talk about it behind their backs, and basically because that group doesn't understand what these are all about. Significant complications, both medically as well as orally or dentally, which we'll talk about, because that's I have to talk about that. And the misperception in the past that eating disorders only affected one class of the population, the well-to-do kind of middle class sort of environment, but it's the whole spectrum. There's nobody exempt from any of these illnesses. So anorexia by itself, if you want a little definition, is just a really self-induced starvation, restriction, and subsequently weight loss. And there's two types, restricting type, or you can have a combination of restricting and you can have binge purging as well in the same sort of diagnosis. The little book at the top, or the square at the top, is really what so that's why I want to flip these lectures around, but that's what the psychiatrist will use to reference and come up with a diagnosis for a patient with any of these serious psychiatric illnesses. The DSM-5, 5th edition. But the criteria for anorexia is simply refusing to maintain body weight at or near what's normal for your age, percentile, 15% kind of either way. One's perception of body image, distortion. So they look in a mirror, they could be just perfect for their height and age and everything, and they still see themselves as overweight. And for women, eventually, with this kind of behavior and this restriction and this down-regulation of metabolism, one of the features in this book is the loss of regular monthly cycle after 3 months. absence. And there's other factors as well. So if you ever have known anybody with this illness, interestingly, individuals can be around food. They actually can work in a restaurant. They could serve it. They could prepare it. They could cut it up. Do whatever. It's the restriction. They have the ability. They've developed that restriction of intake. And one of the prime focus at the eating disorders clinic is to get these kids to eat. Basic, plain and simple, is to get them to eat. That's why they're there. This clinic is the last resort. And that's one of the sort of criteria to get into this clinic, is you've exhausted all your other community supports. And these kids have. Their parents have taken them everywhere. This is it. This is the last stop. And the focus is get them to eat. And eating every meal is a community event with staff sitting down with the patients and trying to get them to eat, even just a little bit. Now, if I told you, what these kids do at great lengths to avoid eating and how they will hide the food, it's just unbelievable, the stuff that I've heard from my assistant, who's a former assistant. Not only hiding food, but then if they're purging as well, and that can get pretty gross, especially around lunchtime. But it happens. You wouldn't have any idea. You wouldn't imagine what they do, what they will think of doing. So there's no problem around food. It's just the ability to restrict it. And ultimately, starvation, when we're talking anorexia, is going to lead to organ shutdown. Things are going to slow down and stop eventually. It's just common sense. So any one of these functions, heart rate's going to slow down. Intolerance to cold, you feel chilly all the time. Changes in blood pressure, changes in heart rate, electrolyte imbalance. And that's sometimes sort of an end-of-life event where the heart just stops because everything is just so messed up. And so those are the sort of signs and symptoms you see. With bulimia, you can have a combination of bulimia with anorexia. There's more association, it seems, with bulimia and use and substance abuse. If you look in the same book for bulimia, this is what symptoms an individual has to really show for a psychiatrist to give a diagnosis. Binge eating twice a week, over a 3-month period of time, followed by regular purging behavior, however that is induced. And we'll talk about that in a second, whether it's chemically induced, whether it's physically induced, whatever. With bulimia, the weight may be more normal for an individual. It may not be sort of anorexic as we know. If somebody's literally starving themselves, they will look at in short order. But with bulimia or binge eating, individuals will compulsively eat massive amounts of food and then experience such guilt and such anguish over it that they will regularly purge that meal by whatever means they can, and then the cycle just continues, and the guilt and the shame and so forth, and it literally affects one's ability to function in everyday life. Complications of bulimia can be more related to the mode of purging or what is used to induce it. So there's a higher risk of aspiration pneumonias. If you're vomiting and it comes up and goes down the wrong way, it's more serious in elderly, of course, and that's usually an end-of-life event for individuals, but can also happen in this age group as well. Ruptures from force of vomiting 3 times a day, 4 times a day. Tears in the esophagus, lesions that can occur, and then just some other possible ways that can come up as a complication. Ultimately, suicide again is going to be an escape route for many people, and we'll talk about that a little bit later this afternoon. So the complications: anorexia, the shutdown of the whole organ system; bulimia, often more to the mode of purging. Interesting term called diabulimia in patients with type 1 diabetes. I can't walk too far, sorry. Sorry. who will administer less insulin in order to facilitate weight loss. So they've actually figured out a way to play with the insulin to regulate their metabolism and eventually lose weight. So something I learned a few years ago. I wasn't really aware of that, actually, until I wrote that article. What are the issues for us? Okay, you want to find out how is it relevant to us in terms of what we see in the patient. Well, we may be the first, not maybe, but often are the first, that's us, in seeing some initial signs of an eating disorder. And the most thing you're going to read about, of course, in the textbooks is the effects on the enamel of continued purging of gastric acids. I think I have a, no I don't. I thought I might have a picture coming up. But anyway, if you look at a scale of the pH, you know, the acidity, measure of acidity in different things, gastric pH is like right one level above battery acid. Okay, so battery acid has got the highest acidity. Gastric pH contents is up above that, and we want something around 7, neutral pH. So you can see how quickly repeated episodes of purging behavior can damage the enamel of teeth, and also the acidity will damage the mucosa as well in the esophagus and so forth. So, but there's other signs that give a clue as to the effects of these diseases. So as I said at the outset, you want to be in a position where maybe you could talk about it to a patient, or, and I've suggested this even when I'm talking to dentists, heaven forbid, you know, you've got a rack of pamphlets on the side of the wall in the waiting room talking about veneers, implants, and all the rest of it. What's wrong with having a few pamphlets about eating disorders, a few pamphlets about diabetes, a few pamphlets of, and you know, the effects on the periodontium? You know, let's branch out. Patients will, I know it, when nobody's looking, might just pick up a pamphlet and stick it in their purse for their friend, somebody else. And that's just opening the door a little bit. Hey, this office is, you know, talking about other health initiatives and not just trying to get my money for, you know, all these restorative things. So the oral manifestations that we see can really be secondary to the nutritional disturbances. I mean, if you're not eating, or if you're eating and purging, nothing is getting in that's good for you. So we have nutritional disturbances, lack of regular hygiene. Often patients are also very depressed, very anxious and depressed about having this disease and not knowing what to do and have nowhere to go. So oral hygiene is often the first thing to go. Some comorbid disturbances such as depression, but also abuse of substances. So patients will have other addictions, and that's not just cigarettes, but other substances. Changes in eating habits, and the side effects of medications. And we'll talk about that in a second. And then the changes, the mode of purging, the physical changes that can occur. So all these possible complications can impair eventually good oral function, affect the teeth, affect their ability to chew. Patients will experience pain, aesthetics will deteriorate, as you'll see, and overall poor quality of life will ensue. At the end of the day, the only escape in some cases is suicide. I know I keep going back to that, but you have no idea how serious that is. Yeah?
How would you bring this up if you noticed it? How do you bring it up to a client?
Okay, so there's lots of, you know, you can read about lots of charts and lots of surveys and stuff, and nobody's going to listen to those questions. But some of the questions you could ask is the changes I see in your teeth. So you're looking at teeth and you see some very significant erosion, and the patient's only 15 or 16 years of age. And maybe complaining my teeth hurt when I have ice cream, or mom may be telling you she's complaining that her teeth hurt when she has ice cream or something cold. Well, the changes I see in your teeth look like somebody who's maybe sick to their stomach a lot. Is this something that you might be dealing with? The changes I see is somebody who drinks a lot of pop and soft drinks. That might help you rule out, you know, and say, no, I don't do that. That's fair. So then you go to the second question. You know, you got a pretty good judge of responses. somebody who hesitates or looks away, doesn't look you in the eye, things like that. That may be your clue. Yeah. So, I don't need to show you this, but let's just talk about mucosal lesions. Well, you can have deficiencies in vitamins. So this is part and parcel of your nutrition course, I assume. What happens if you have vitamin deficiencies? What happens to the mucosa? Vitamin B group in particular. What happens with iron deficiency? So the changes you're going to see on the tongue, for example. There may be lacerations to the mucosa secondary to somebody sticking something down their throat to induce purging behavior. Whether it be their fingers or whether it be some other little device that they've come up with. And so iron deficiency, you can look up any good oral path textbook and this will tell you, the pictures will be there. Vitamin B12 deficiency, the changes that you can see on the tongue, for example. Here's the changes that you see on the knuckles of one's hand, and it's basically calluses here from repeated trauma of somebody using their hand to induce vomiting, the rubbing of the skin against the teeth repeatedly. So it's repetition, it's not just once. And this is called Russell's sign, which is the physician who actually came up with this diagnosis, this disease, back in 1970. So it's not that old. Here's another example. If you looked at that in somebody's mouth, the first thing that comes to your mind would be what? Yes. Go for it. Go right to the end. What's the first thing you see that? It is an ulcer. Yeah, you're right. It is an ulcer. It's ugly. It looks terrible. What's the first thing you're going to think of? What's the first thing you should think of? Cancer. Right, exactly. This is a bad ulcer. There's a fancy name for it at the top, necrotizing silometaplasia. You're going to see it today and you'll never remember it again after this. It's due to ischemia. It's due to blood supply being shut off. The blood supply to the minor salivary glands in the palate is cut off. Just like you have a heart attack, cut the blood off, that part beyond dies. Same here. This was one of, I think, 8 case reports that I could so far find in the literature, in the pathology literature, oral medicine, found in bulimia, patients with bulimia induced by trauma from damage, sticking something down into the throat and traumatizing the mucosa and causing that loss of blood supply and creating this ulcer. And so I just put it on there for interest. However, cases like this, of this lesion, just for your own interest, you don't have to remember it at all, but if this would be biopsied, the dentist would probably want to biopsy this or send it out because you're thinking cancer. And actually in the literature, sadly, there have been cases that have been sent out for biopsy and have been misread by the pathologist. It's probably not an oral pathologist, probably a general pathologist, and diagnosed as squamous cell carcinoma. And patients have had resections of their maxilla, major surgery for something that is not cancerous. It'll heal in 6 to 10 weeks. It will go away. The body will heal itself. So that's just a little aside, but this has been documented in patients with bulimia. Gum disease, gum lesions, vitamin C deficiency, scurvy is, associated with that. You'll get swelling, periodontal problems, bleeding, ulcerations, and so forth, gingivitis with poor oral hygiene. So you get some reddening of the tissues and so forth that you've seen much of that already. Changes to the teeth with respect to the erosion with gastric acids and the effects on the teeth. There it is. So right at the bottom is battery acid, and stomach acid is next up on the bottom, and then where the green is what we want healthy. So you've got that pH hitting those teeth regular basis for months and months and years on end, and you can see where you end up. But there's other causes of erosion too that you should be aware of, I would think. Not just bulimia, but patients with GERD, gastroesophageal reflux disease, very heavy, frequent reflux can cause this. Alcoholism, end-stage alcoholism. Sjogren's syndrome, if you've ever heard of that, you probably haven't, but you should know because it's very common, especially in females over the age of 50. Dry mouth, dry eyes. Patients who work in pools, chlorinated pools, manufacturing, and so forth, and substance abuse, big cause of this of erosion too. Very rapid with methamphetamines and so forth. So just throw that out there so you know that we're not just talking about bulimia. But here's the sort of characteristic pattern on the palatal surfaces of the maxillary teeth. You see that over time, that shiny appearance. It looks like it's polished, like almost like glass. And it's just continually being eroded away. And so usually on the palatal surface, the upper teeth, the tongue often will protect the lower teeth a little bit more during the act of vomiting and so forth. But patients who are dealing with this for a better part of their life, with amalgam fillings, eventually the erosion is going to cause those fillings to appear like they're coming out of the teeth. They aren't really, but the tooth itself is going down. Eventually, as you take more away from the teeth, particularly the upper anteriors, they're going to thin out. And what happens when teeth thin out beyond what they're supposed to be? They start to chip. And then it becomes an aesthetic concern, and then maybe the individual is now going to be sort of more conscious and looking for, what can I do, and having to deal with it, can't keep it secret forever. So we get that chipping effect, and that's where the aesthetics becomes a factor for individuals. As well, as I read in this case, this girl was also in pursuit of activities such as, running around, and so forth. Physical activity, consumption of sport drinks, which are very acidic, and something you need to always keep in mind when your patients come in and say they drink a lot of this stuff and pop and beer and wine and so forth. Very acidic. It may be sugar-free, but that's only half the battle. So in some of these drinks, these caffeinated beverages or carbonated drinks are actually used for energy. So instead of them having to eat something, they can drink these and get the energy and get that energy to then do more physical activity. It's all in the pursuit of one goal, and that's to lose weight. Caries is heightened, increased use of these beverages and chewing gums and everything that's not sugar-free, particularly during the binge eating focus. So sensitivity, and you've seen all these diagrams from all the dental companies talking about sensitivity. That's what happens. Patients start to feel everything's sensitive. My teeth hurt. Another manifestation of bulimia is actually extraoral. And sometimes it can be the first manifestation before the erosion really kicks in, and that's the parotid gland becomes swollen, almost like mumps, bilateral swelling of the parotid glands. And so that may be a clue. The patient doesn't have mumps, but this may be a clue that something else may be going on. Other changes, patients will complain of burning sensation, loss of taste, that nothing tastes the same, so loss of taste sensation, and so forth. And again, depends on how many years someone is dealing with this disease, which is in many cases a lifetime. And in some cases, there have been documented kids with orthodontic brackets who've lost the brackets. The acids dissolve the cement over time, and they fall off, and they have to be replaced, and so forth. So just, again, this is something you'll be able to access if you wish, just to compare the two. But the erosion, the sensitivity are kind of the key top 1 and 2 features. So how can we help a patient who's dealing with this disorder, this disease? What can we do? If we, know out and out that someone is dealing with this illness, and they're coming to us for help, or maybe the physician is referring them to us to get some additional help, or somebody is still dealing with this disease, getting help, but needs sort of intermediate assistance to try to lessen the effects on the teeth. One of the things is obviously reducing the frequency of acid exposure onto the teeth, which is really what they're seeing the physician for. However, if they're not seeing the physician, we can do things, we can help them in the meantime to lessen this exposure. Ultimately, cessation of the vomiting behavior is going to be the turning point. ensuring good hydration. Dry mouth is a particular problem with individuals because they're dealing with depression as well. And I put this slide on now, and you'll see it again later, but I won't spend any time on it. Depression becomes a very comorbid disorder with patients with eating disorders. And so with depression, and you may not have seen this yet, I can assure you it's out there, and I've seen patients who come in, sit in our chair. When was the last time you brushed your teeth? I don't know. I can't brush them. I don't brush them. I haven't brushed them. You know, their mouths look pretty disgusting. I mean, nothing bothers me at this stage anyways. You think you've seen it all, but actually there's always something that comes up. But it looks pretty crappy. Yeah, and they just don't brush. They miss appointments. They lose interest. So you get skipped appointments. Non-compliant to what you're telling them. You come right out of this program and you're going to get the first patient in practice and they're going to brush just like you were taught to tell them, and they're going to floss and do everything just perfectly. And patients will not even follow your instructions. It can be very frustrating if you let it get to you. But that's just the nature of the business. The side effects of drugs, medications. So we get, a million slides you can show poor oral hygiene. But it's the medications that really add a double whammy for individuals with this disease. Antidepressants in particular, they will be taking to assist them in managing, other underlying factors that are going on in their life. And you're going to see a lot of these meds on your medication profiles for patients that you're taking. Don't be afraid to ask the questions why. As soon as you see an antidepressant or an antipsychotic, everybody kind of shuts down and wants to go on and avoid it. And in fact, that could be the key point in affecting their ability to look after their teeth and so forth. And there's a whole bunch of names out there that you will recognize very quickly. And usually the main side effect of these meds is dry mouth. A few other changes too. Patients may complain of increased grinding of their teeth. Secondary to these medications. You might have to suggest a night guard, for example, while they're taking these medications. And some questions we can ask patients about dry mouth. We can ask them some things. Does it seem like your mouth is drier? Do you feel like your mouth is dry? There's two different things. It's the patient telling you their mouth is dry, and it's you looking in their mouth and seeing if it looks dry. Usually, if you see it's dry in the mouth, they're going to tell you it's dry, but sometimes they complain of dryness, but it doesn't look dry to you. Xerostomia is the subjective complaint. Hyposalivation is objective, what you see. So, do you have trouble swallowing, chewing? Do you sip a lot of liquids to help you swallow? Yeah, I do. I always have water with me at meal times because I find it helps me. Any dryness or cracking of the lips, any sores in your mouth, last time you saw a dentist, could be years ago, any bad breath and so forth. So this is all, again, you're going to be taught this if you haven't already, and most of you know this, how to sort of educate a patient about dry mouth, very important. No amount of scaling and root planing and anything that you're going to do for a patient is going to matter anything if they're suffering from dry mouth and nobody's talked to them about this. It's just not going to matter at all. So this is so important, especially nowadays with all the medications out there. So there's lots of things that we can do. There's lots of things that we can tell patients not to do that will make it worse for them. And so we have to be able to counsel them on that as well. So I'm not endorsing any particular products, but there's a limited number on the market that we have available in this country to use. And we've used it in the hospital all the time, wherever we can for our patients. So another objective is to neutralize the acids in the mouth that somebody's bringing up during purging behavior. Mouth rinses, such as sodium bicarbonate, very simple. Teaspoon of baking soda, 8 ounces of water, very neutral rinse for the patient. Don't go out and buy the Listerine at how much a bottle and stuff like that. It's just a waste of money. Increasing resistance to enamel. Here, take this toothpaste. It's high fluoride and it will help you. Use it once a day. You know, give them something, give them a choice, give them something to take back, or even gels in trays, if they will accept that as well. Anything. Avoid brushing. This is almost one of the most important things. Don't brush your teeth after you vomit. You know, what's the first thing, natural thing you want to do? You want to brush your teeth, because it's just disgusting. And what you're doing, what a person's doing, is brushing away the enamel that's just been nicely softened. That layer's gone. Next purge, brush, that layer's gone. You're just helping the process. So avoiding it for at least an hour, substituting the rinses in place, and making sure that when they do brush, it's the correct way, gentle and so forth. Caries prevention, whatever we have to throw at patients to prevent caries. We're all about prevention. That's why we're in this profession. Okay, we're actually focused in our profession to put ourselves out of a job. That's our goal. It's been like that since dentistry came along. When you think about it, we're the only profession that's focused on eliminating our jobs. It will never happen, but that's what we're doing. We're preventing. I just put this on here quickly at the end. Here's a survey that came out last year out of the States, and it actually surveyed in eating disorders clinic in the States, a program, a number of people, and asking them certain questions about their eating disorder and any changes that they notice in their mouth and teeth and so forth. And the average or mean age of the group was 27 years of age, very young. And over 93% had one or more dental problems. Okay, so, and the most significant problem was sensitivity, teeth or gums. 70% had sensitivity. Very close second was erosion, enamel loss on the teeth. And then you can go down, with the loss of enamel, you've got changes to the color, shape, and so forth that we saw, the chipping of the teeth, pain, usually sensitivity, thermal sensitivity, oral lesions, decay, and dry mouth, and so forth. So these are all what they checked off. And then it asked them, what do you do? What sort of care do you do for yourself after your purging behavior? Well, most of them rinsed, but a third of them brushed right after. They just pulled out that good old toothbrush and just scrubbed away. 30% of the group surveyed felt that an oral health professional was kind of helpful, but most of them, in fact, turned to the internet and got their information. So I had a young girl come to me about last fall from the eating disorders unit, and she came in and she was very heavy into purging, but at the present time she wasn't as much. She was kind of cyclical in this, and so I had a conversation with her. I brought it up and I said, how often have you been purging? And she told me, and I said, so what do you do afterwards for your teeth and your mouth? And she just said, I know all about that. She says, I checked on the internet. I Googled it. And she actually told me what I was going to tell her. I said, well, you've actually, you've stolen my thunder because I can't tell you. She actually researched it, okay? And that's where, it's a fact. Everybody gets their information. But I still feel at the end of the day that having that information in the office would be something that would tell patients that you care. You care a little bit more. So with this group of people, the final question was, what can we do to make it better for you from our perspective, from our oral health perspective? What could I do? What could the dentist do, the hygienist do? And the first thing was communication. Communication through information on the dentist's website. How simple is it to have a link to another public health organization? What about promoting vaccination for human papillomavirus for our patients? Because we all know what human papillomavirus is contributing to. Why shouldn't that be in the waiting room or on the website? So same with this. Display relevant material. How about a screening questionnaire on? Some of them said, how about a screening questionnaire on a medical history form? There are some forms that you can check off bulimia, or you can check off depression and so forth. And the last one was encourage discussion, less negative vibes from the staff. that was one of their comments. I'd like to feel more comfortable bringing this up, perhaps, to the hygienist or to the dentist. So those are the comments they made. Definitive dental treatment, of course, has to be delayed until purging behavior is eliminated. Otherwise, it's just going to fail. Everything will just dissolve away, literally. And the same with anorexia. I mean, you can't get the patient in there and do multiple implants, you know, if they're still in the throes of restriction and not stabilized and things like that. It's just not common sense. And the same with bulimia. Then there's a lot of reconstruction, and you see a lot of cases in the journals where they have had to reconstruct an entire mouth with crowns and so forth to make up for the damage that's been done, but not until the behaviors are controlled. So early recognition and treatment, I think we can play a role. It's not on every patient around every corner, but it is more frequent than you would actually think. And the impact that eating disorders have, not just on the person, their physical health, but also their oral health, which, as we know, is part of physical health. And that's the way we got to think. So, with that, that's good. I'm finished. Do you have any questions? I try to answer them from my understanding of these diseases. Yeah.
Where would
Jays win too? Take us going down next week. So.
where would you get like information or pamphlets? Like, would the health unit have something like that, or
The health unit, the hospital. Yeah, the hospital would have it. And there's stuff. If you go like on Ontario Shore's website, I think there's a section where patient info or something, and it's actually got. You can print out a sheet on. Schizophrenia, sheet on depression, eating disorders, stuff like that. Yeah.
okay.
Yeah, there's stuff. And so you could have a link. If you didn't want to have paper, you want to save trees, but you know the dentist has a website. And you could advertise that in the office, say, see our new website with these things.
If you do something like, do you have the right to go and tell the parents that?
Good question. I was hoping nobody would ask that. That is difficult. There's no age of.
Sorry, I didn't hear the question.
Oh, go ahead.
That's okay, you don't.
Just if you do suspect something, like if you have the right to go and tell the parents that you do that.
Yeah. So in Ontario, there's no age of consent for treatment, first of all. So you could have a 12-year-old could come in and if he understood everything about a heart transplant, get his heart transplant. But the consent piece is for paying for it, in particular for dentistry, and the age is 18, I believe, for financial things like that. So that can be very difficult because you can have the patient, she's 15, she's 16, saying, you've identified this, you've had this discussion, and she doesn't want you to say anything to her family. What do you do? Well, I think you have to sort of, as much as possible, encourage that individual. Maybe spend a few extra minutes, maybe in a quiet room or something, you know, maybe with another staff person, just having a bit of a conversation. You know, think about it. You know, we're here to talk about this. We're concerned about you, that kind of thing. I think if it reached the point where it was actually threatening the person's health, affecting their health, I know that the college has the viewpoint that it's our obligation to report to the parent. But telling the patient, I'm sorry, but I'm really concerned about what's happening to you, and I'm going to have to tell your mother or father, but I'm telling you that I'm going to do it. I'm not going to talk behind your back. Yeah. Because first and foremost is the health of the patient.
Yeah.
You know, that's got to be that. But if you can initially get them to come around and maybe talk to their physician, and maybe go talk to your family doctor and let me know what they say. And yeah, it's empathy, it's understanding, acceptance. All those things play a big role. Yeah, it's a good, excellent question, and there's no actual gut answer. Yeah. Anybody else? No. Okay, so I guess
That's it?
Yeah.
All right, thanks again. Okay, so we're done a little bit earlier. So like I said, we're gonna have this posted. Sunny's gonna do the video for us. It'll be posted on the Durham College website on YouTube, so I'll make sure you get the link and everything. So we all learned a little bit something here, okay? So that's definitely for your Unit 4, and hope you enjoyed it. Okay, you're done for the rest of the day. Please see Dr. Clark again in what, an hour or so?
3 o'clock.